We are live now.
Good evening, everybody, and welcome to Bombay Spine Society monthly academic meeting, which is basically a fellows training program. Today's topic is on cervical myelopathy, and for this topic, we will be having three talks where we will be discussing the etiopathogenesis, symptoms, and diagnosis of cervical myelopathy and disorders related to it by Dr. Aaditya Kashikar. Thank you, Aditya, for joining us and giving this talk. We will be having question answers after every talk. Dr. Akhil Tawari will then take over on classification and surgical approaches. And Dr. Mazda Turel will be then talking about complications and prognosis, which is a very important aspect of this as well. After that, we will have case discussions on cervical myelopathy, and even if you're on YouTube, you are free to ask questions on it. While there, we'll try to answer your queries. And Dr. Bharat Chaubey is our senior faculty as well, who will be joining us soon and will be part of our discussions. I would, at the outset, I would also like to thank Intas for sponsoring this meeting. And as an academic organization, Bombay Spine Society, we want to thank Bombay Spine Society, and Bombay Spine Society has always been involved in the academics and will continue to do so. So without further ado, I invite Dr. Aditya Kashikar, who's a spine surgeon here in Bombay, to please start his talk.
Good evening, everyone. I'll be sharing my screen now. Can everyone see this?
Yes.
Yes, Akhil.
Yeah. So, in our clinical practice, we always see patients, especially elderly gentlemen with difficulty in walking, imbalance. They have a history of frequent falls, sometimes associated with weakness in their extremities, gallbladder disturbances. And you come across such kind of MRI picture if you ask for cervical spine, depending on your clinical suspicion. So as we see over here, severe cord compression right from C3 to C7 level, and on asking further CT scan showed OPLL-like picture. So for next 15 minutes, I'll be talking about cervical spondylotic myelopathy, its etiopathogenesis, symptomatology, and diagnosis. So this term was originally described by Stonides in 1928. Over a period of time, its natural history, imaging, treatment options have evolved quite a lot. Still, we don't know the exact means the certain set of patients, why do they get myelopathic presentations, and few patients, why they don't get myelopathic features in spite of having severe cord compression, it's still unknown. So there can be static and dynamic mechanical factors associated with this condition. But one thing is for sure, there is no acute mechanical insult. There is an absence of hemorrhagic necrosis in the cord. And so basically chronic and progressive nature of the disease likely to compensate, have compensatory mechanisms within the cord. So there are static mechanical forces which are direct injury causing the injury to the neuronal population and glial cells. And whereas dynamic repetitive injuries, whenever flexion extension is happening, causing stretches on the axons and making them vulnerable for secondary injuries. So there have been postulate that ischemia is associated with this condition. In cadaveric studies, they saw that the branches of anterior spinal artery is getting stretched in such conditions, thereby compromising the blood flow to the axons and thereby affecting corticospinal tracts, which are mainly affected in CSM. So age-related degeneration, it's causing a decrease in blood flow and thereby causing decreased perfusion of the cord. Further, the deformities like kyphotic cervical spine further interferes with spinal cord vascular network. But is ischemia a real cause? So the argument against that is whenever there is see the role of ischemia in one of the principal arguments against the significant pathological role in ischemia is that ischemia, despite eliciting an apoptotic response, usually leads to cellular death via necrosis and not through the apoptotic pathway. Evidence indicating that the oligodendrocyte and neuronal cell death that has been demonstrated in human and experimental studies have shown the result of appears to be a result of apoptosis, has fueled the argument against the ischemic injury. So that's the reason why this question still remains unanswered. So there are certain secondary pathological events also happening due to this chronic compression. So one of them is endothelial cell impairment. So whenever there are these static and dynamic mechanical forces getting applied on the spinal cord, they are causing decrease in number of cells, I mean to say number of vessels, indicated by decreased staining of laminin, which is a protein of the basement membrane of the vessels. So whenever these decrease in endothelial cells happens, it causes disruption of the blood spinal cord barrier. So these endothelial cells are the important part of blood spinal cord barrier. So whenever there is decrease in these, they further accentuate the inflammatory and vascular dysfunction. So inflammatory reactions are already in place because of the chronic compression, but the further decrease in number of endothelial cells and altered vasculature aggravates the condition. So neural and oligodendrocyte cells undergo apoptosis even during the late stages of this compression. So ongoing oligodendrocytic apoptosis away from the compression of the center was very well associated with axonal degeneration. So there are certain markers like tumor necrosis factor alpha, mitogen activated protein kinase pathways, etc. They have been identified as potential apoptotic signal pathways in CSM. There is also evidence that blocking these signal pathways results in decrease in level of cellular apoptosis, thereby improving the functional outcome in CSF. So it is obvious that only when identification of these extra and intracellular apoptotic pathways implicated in CSM is complete, then only we'll be able to come up with novel neuroprotective treatment. So these are the key pathological changes occurring in the setting of spinal cord compression secondary to degenerative changes in the cervical spine. So international classification of the disease in 10th revision. These are the list of conditions which lead to myelopathy in cervical spine, degenerative cervical spine. So if you see the degenerative cervical myelopathy, so there can be spondylotic degenerative osteoarthritis, it can be secondary to congenital anomalies, or it can be non-osteoarthritic degeneration. And these are the sub-classifications in each of these classes. There are certain genes also associated with particular type of issues, like particularly, just for example, ossified ligamentum, ossified posterior longitudinal ligament. So particular condition is supposed to be linked with these kind of genes, studies have shown. Now we'll come to the symptomatology part. So most of the times, these patients come with these three main symptoms, where there is imbalance. They say they get frequent fall, or they feel they need support while walking on uneven surface, or they cannot walk independently. They need support while walking. Second and foremost symptom is fine motor dysfunction. But obviously, patient is not going to tell you about this fine motor dysfunction. So you have to elicit these points from patient in your history. So you can ask them whether they have difficulty in buttoning their shirt, or is there any change in handwriting. So if they don't know how to answer that, you can ask them, are your checks getting bounced back from bank because your sign is not matching? Or they are not able to eat with hand or by holding the spoon. They have difficulty in unlocking their door, or difficulty in wearing clothes, or making pony for their hair. They also present with ball bladder dysfunction sometimes, with urgency of urination. They are not able to hold on to your urinary urge. Other symptoms associated are neck pain. It can be present or it may not be present. There can be radicular symptoms associated with this condition, or may not be associated also. So radicular symptoms in terms of pain, paresthesias, tingling, numbness, pins and needles expression can be different. So neuropathy component is additional factor one has to keep in mind when you assess these patients. Now we'll talk about signs. So usually their gait is myelopathic, broad-based, unsteady gait. While turning especially, they tend to fall. They might be having motor weakness. Not necessarily each patient with this condition will have motor weakness, but you can experience patients with upper and lower limb weaknesses. Hyperreflexia, clonus can be seen in lower limbs, ankle clonus, knee clonus. There are conditions like tandem stenosis, where there is associated lumbar canal stenosis also, where you will get hyperreflexia in upper limb, but absent or hyporeflexia in lower limbs. So Babinski's test is positive in such patients. Romberg's test is positive. They have, we can see in severe chronic suffering patients, they present with wasting of intrinsic hands of muscles. Finger escape sign. So this is one sign where on keeping all fingers in extension and asking them to keep it in adducted position, the little finger stays away from other fingers. So this is one of the features of chronic cord compression. Hoffman's test is positive, where on flickering the middle finger, there is flexion of the index and adduction of the thumb. So these are other ways of eliciting your plantar or Babinski's test. So the last part of my talk is the investigation part. So as we all know, these are the mainstay of investigations, where in order always ask for X-rays, because they are important in surgical planning. Anyhow, the surgical aspect will be talked about in following lectures. So X-rays, MRIs and CT scans are must. Sometimes flexion extension MRI CT is also important, and MR spectroscopy, which is not much in practice, but this is also for completion of topic. I have included this. EMG, NCV, SCCP studies also usually I carry out in all my patients, and I always involve neurologists before I take a patient for any surgical intervention, because I need to rule out any central cause contributing to the ongoing spinal issue. So X-rays, standard AP view, lateral flexion extension. Sometimes X-ray itself can give you indication about the OPLL. So in this case, here, you can make out retrospectively, if you carefully see, even on lateral view, OPLL part can be seen, which is shown by this yellow vertical line. MRIs are mainstay of investigation. So usually you see evident cord compression with or without cord edema, seen as hyperintense signal within the cord. So axial cuts showing very severe cord compression. So conditions like OPLL, where you want to know the extent of the OPLL, its nature or anatomy of OPLL. So CT scans are must in such cases. So relevance of flexion extension MRI. So for explaining this particular thing, I would like to quickly show this case. This is one of my case where 54-year-old male presented with numbness throughout his body, which was increasing in the last 2 months. And when he came to me, he was non-worker. And there was bilateral hand fine motor dysfunction, no gallbladder dysfunction. So and he came to me with this MRI, which was done somewhere else. So when I saw this, there was listhesis at C5, C6 level. And if you carefully notice, even the axial cut, what we see full facet sign in lumbar spine most of the times, which is very rarely you can get in cervical spine. I saw this full facet sign like picture on axial cut. So I felt that this patient is having, it's not only the compressive part, but there is instability aspect also to it. Even higher up also at C3, 4 level, there was compression. So advised for repeat X-ray, MRI and CT, this time flexion extension, because I anticipated instability. Surprisingly, there was no instability evident on X-ray, which is very, very, very surprising in this case. But when I did this extension MRI and the flexion MRI, you can very well see how cord is getting compressed and again getting relieved on flexion at C5, C6 level. So it was not only the cord compression part, but also there was instability part as well. Even the CT also showed there is increase in listhesis at C5, C6 level. So I did this surgery where I did laminectomy and lateral mass screw fixation. So the last part in this is MR spectroscopy. This is kind of, this gives us understanding about the microstructure and metabolic abnormalities in patients with CSM, even in normal looking areas. So usually N-acetylcysteine to CR ratio is decreased, and there is lactate signals are getting more in such patients when we carry out MR spectroscopy. So this is one normal graph. This is the abnormal graph where there is increase in lac graph region. But there is limitations of MR spectroscopy because there is pulsatile flow of the CSF with each heartbeat, which disrupts the signals. And basically, and this, it is known that microstructure abnormalities were reported in spinal cord proximal to the compression level using tensor diffusion imaging. So take home message here is CSM is a degenerative condition due to multiple complex phenomenon like static dynamic events or vascular ischemic apoptotic phenomenon. We need to elicit key points in history to come to final diagnosis. Good clinical examination is utmost important, and one should be able to elicit UMN signs. And after carrying out proper investigations like X-ray, MRI, CT, one can plan surgical intervention in such patients. Thank you.
Thank you, Aaditya. Before we go ahead, I want to also welcome Dr. Bharat Chaubey for joining the meeting. He'll be a senior faculty here to ask and answer any questions if we do have. Aaditya, I wanted to ask you now. It was a good talk, and we got to understand about the symptoms, signs, how the patients come about. But which is the commonest symptom that you see with these patients coming to you with?
So the commonest symptom is imbalance. Most of the times these patients, they present with imbalance. They always say that they have a history of frequent falls or they need support, which was not there earlier. The case, they find it difficult while walking, they need support. They don't feel confident in this manner. They say that chalte hue confidence nahi lagta hai aajkal.
Right.
So,
Right.
so that is the commonest symptom what I see when they come up with. Obviously, the fine motor dysfunction, as I said, they don't come up with that history. You have to elicit that. But the commonest symptom is
Those patients go to Mazda because they are rich patients and they count money, so they have difficulty counting money. So Mazda gets those kind of patients. But that is also an important thing when patients do come with that, where they have difficulty in buttoning shirts and all, and so fine motor, even their signature starts changing, and that also is something that we come up with.
correct.
I'll push this question to Dr. Chaubey. Sir, in your practice, when these patients, when they come to you, what is the number one symptom that brings your alarm bells ringing, and you think, oh, now I have to investigate this more thoroughly, and maybe this patient may need some proper intervention. So we can't hear you. Maybe you have to increase your volume or unmute yourself, please. Not yet unmuted, sir.
Yeah, am I
yeah.
audible? Yeah.
Yes, please go.
So basically, when they come, a gait disturbance is one part, and then there's some kind of paresthesia, numbness, tingling, uh, and those things what you have already narrated. But primarily the gait disturbance and paresthesia.
That is the most important.
Yeah, and the the weakness part is always not a very defined weakness. Most of the time there is a spasticity, and the weakness is not always we can judge in terms of the grade, like grade 3, grade 4, grade 5, because it is always masked by the spasticity.
Right, sir.
So that is the two main things which we alert us.
Sir, very often we get these patients who have got, they've come for symptoms of back pain or, not your routine gait imbalance, etc. And when you examine these patients, you find that there is a little bit of hyperreflexia, maybe a little bit of increased tone. So it's not obviously affecting them because they are not complaining about it. So at what stage do you want to start investigating? Would you investigate any patient who has got any upper motor neuron signs?
Basically, any upper motor neuron sign, if it is there, I should definitely investigate if there is any upper motor neuron sign. Some anxious patient, they do get the hyperreflexia, but they will not get the Babinski positive. Hyperreflexia associated with the Babinski sign. And when the relative says his gait is not normal, we are observing that he has some kind of an inconfidence in him. So that is the time we think that there is something which is there and you must investigate.
Yeah. Akhil, I'll push this question to you as well. So these patients who come in with, say back pain, low back pain, but on investigation, you have on, routine examining, you see that there is some spasticity and all. Do you think you're going to get something on the MRI every time? And would you investigate them?
So usually I keep a very low threshold for investigating, as Dr. Chaubey sir said.
You'll
In
get an
our
MRI
country,
done quickly.
yeah, in our country, MRI is easily accessible. We don't have such issues of access. It is better to or more on investigations.
And do you think you're going to
actually,
get?
Yeah, many
Do you
times
think
what
you're
I
going?
do. Yeah.
Go ahead, sir.
Screening MRI. If I have any doubt, at least I will do the screening MRI. And if there is anything which is visible, then I will go for the detailed MRI. So many times I do the screening MRI.
Right. And so how often do you actually find myelopathy or actual findings in these patients who have some signs, subtle signs?
Not always. Not always.
Great, great. So the very good take-home message is that number one is that you must get a screening of the whole spine done whenever we are investigating these patients. Especially, I think that we are the tertiary care centers, so we are asked to see the patient last, and so if we miss these, it's going to be a problem. So we should try not to miss any of these pathologies, and so always get a screening done. Number one. And number two is that upper motor neuron signs are positive in normal population as well. Almost maybe up to, it's said up to 10 to 25% of population may have subtle signs, and they may be absolutely fine all throughout. So we have a few questions from the audience, from our fellows. So I'll put one of them. If is Mazda, are you there? So the first question is, are there any signs from Dr. Mukul Jain? Any signs or tips to differentiate cervical spine myelopathy from motor neuron disease?
So, motor neuron disease will always present with a combination of upper motor neuron and lower motor neuron findings. However,
Good point.
However, there is a condition called as cervical spondylotic amyotrophy, which is a rare condition which presents with severe lower motor neuron dysfunction in the upper limbs. And it may be mistaken for MND or ALS, as we call it, or motor neuron disease. So, and there is a significant compression in the cord. And when we were at Vellore, we published a case series of several cases of this particular condition called as cervical spondylotic amyotrophy, where you have predominantly lower motor neuron symptoms in the upper limbs, but you have upper motor neuron symptoms in the lower limbs, such as spasms with exaggerated reflexes. But you may find absent reflexes in the upper limbs, no Hoffman's sign, and these patients behave like a central cord syndrome. So it's very important to clinically ascertain based on the radiology as well as the clinical findings. It is this particular rarity that wants me to do an EMG. Very, very rarely do we ask for EMG or nerve conduction studies as far as cervical spondylotic myelopathy or degenerative spondylotic myelopathy, as we call it now. Degenerative cervical myelopathy is the new terminology that most people use. Very rarely do we ask for a nerve conduction on EMG, and this particular condition might help you differentiate whether the anterior horn cell involvement extends beyond the upper cervical region into the lower limbs as well. It is of importance to note that patients with motor neuron disease have very, very late, if at all, they do bladder involvement. In cervical myelopathy, bladder involvement is pretty early. A lot of people, if not present with overt bladder dysfunction, they will present with at least increased frequency. You might very subtly find that they're waking up more often in the night to pass urine. So those are the clinical features which will differentiate a motor neuron disease from cervical myelopathy, cervical compressive myelopathy, whatever etiology is.
Great, thank you. In fact, I was going to follow up on the question on how to differentiate, and you've already given us an answer. And so these nerve conduction studies and EMGs are quite useful in differentiating them, you would say, or at least would help give us some.
Particular, if there's a very gray zone, most often they're not useful, and it's the nerve conduction study itself is very, very dependent on the person doing it. So that's very important that someone who's absolutely well versed in understanding nerve conduction and
need a good person to see.
But in this particular condition, yes, it's useful.
Yeah, thank you. So we have a few questions. So I'll go through them because
Yeah,
it's important
I will add something here.
Yeah.
Yeah, you see, basically the paresthesia part, like sometimes the burning, and the altered sensations, which will not be a part of the motor neuron disease. And at the same time, we always do SSCP and we have also seen that sometimes the peripheral neuropathy, like a diabetic patient, and the myelopathy coexists. So all those patients who have a very predominant polyneuropathy and the cervical myelopathy, you must know in advance, because that is a very common association nowadays I see, particularly in the long-standing diabetic patients.
Right.
Prognostication point of view, this point is very valid, what Dr. Chaubey said, because if they have diabetic peripheral neuropathy, so like post-surgery, we are taking care of the spinal aspect, but the neuropathy component is going to be there. So their paresthesias may remain post-op also. So we need to tell them well in advance pre-surgery that your in view of your neuropathy, your paresthesias may not go.
Yeah, and I think that's a part of your counseling as well,
Yep.
overall counseling, which we will come to later on after maybe Mazda's talk about the results that you can expect with these procedures. Following up with what we are discussing now, there's another question from Dr. Ravindra Kumar on can these cervical degenerative myelopathies, can they show any lower motor neuron features? I think it's best you take it. I understand that it could show low motor neuron features maybe in the upper limbs, if at all. But yeah, please take that question, Mazda.
Yes.
So he's
So, like I explained to you, it's very unlikely that it will show lower motor neuron features in the lower limbs. It will show upper motor neuron features in the upper limbs, and that's because of significant T2 weighted intramedullary signal changes. Either there's edema in the cord or there is venous congestion, both which eventually leads to edema. So you can often find low motor symptoms in the upper limbs, and that should not confuse you. If you see a significant compressive element on the MRI, and the patient is clinically symptomatic for features of cervical myelopathy, and has at least 2 long tract findings on clinical examination, then one should decide to go ahead with surgery.
Thank you, Mazda. So I'll go to the next question by Dr. Tausif on how to grade motor power in case of cervical degenerative myelopathy with spasticity, as the MRC grading is for normal tone. Akhil, can you answer that? Can you take that question?
Yeah, I think if there is a lot of spasticity, we cannot actually grade. If there is a lot of spasticity, so spasticity takes precedence over the power. And unfortunately, there is no other way to do it. It's only then if the patient is able to walk, then you know that it is at least grade 3+ or 4.
Yeah. So
Or no
it's, yeah,
spasticity, you can.
I think we just go by functional versus non-functional power at that stage. So the next question, Aditya, for you. Dr. Mukul Jain has actually jumped the gun a little bit, and he straight away asked a question on tandem stenosis. So if whenever we have tandem stenosis, do we usually operate them in a staged manner, or I normally just do them at the same time, one after the other. But which one do you do first, and which one do you want to do next in tandem stenosis?
So frankly speaking, in tandem stenosis, whether it's double tandem or triple tandems, because there are certain patients where you can see compression at all 3 levels, cervical, dorsal, and lumbar. Whichever may be the condition, tandem stenosis, I'd operate both conditions in same sitting. I have luxury of team with me. So we 2 teams simultaneously operate, one at cervical, one at lumbar level, but we operate at same sitting, frankly speaking.
Yeah.
I will add to it.
Yes, yes,
Whenever,
please.
if you are the alone surgeon and you have to do both, better you do the cervical first, because you
Absolutely.
because you are keeping the neck in extension. You cannot keep the neck in extension for a longer period. So finish the cervical and then go ahead with the lumbar, dorsal, whatever you want to.
Yeah, I agree with you, sir. In fact, also in the cervical spine, we use the burr a lot whenever we are doing those decompressions. So it may be better to get that done and out of the way while you're still fresh, and then go on to the lumbar if you're doing it at the same time. Also, sir, supposing follow up to this is that if you have to do an anterior cervical and then a lumbar, posterior, obviously posterior lumbar decompression, which one would you do first?
Anterior cervical I will do first if I have to do the anterior cervical, and then probably I will stage the surgery. Many times I prefer, if I'm doing the anterior cervical, then lumbar I will do in the same admission, but on other day.
Why is that, sir?
A reason is, suppose if you're doing the anterior only, and then you have to, again, you have to change the position and everything. And most of the time, these are the elderly patients. You have to monitor what you have done right. So you have to done right. So I'll see that my cervical surgery went on well. The patient has no problem. And then the lumbar surgery is a short surgery. And after 2-3 days, I do the lumbar surgery. If I have to go anterior surgery.
Normally, what I do in those cases, sir, is that we do the lumbar first, and in the same sitting, then turn the patient around and do the anterior surgery. Because
somehow I always give the priority to cervical.
Yeah, actually, sir, if I do the anterior cervical first, then turning the patient around while the fresh wound becomes a little bit more tricky.
That is why I stage it.
Yeah, whereas if I do the lumbar first, I can always turn the patient supine, and it's good for the lumbar spine to have a nice little bit of compression while we do the cervical work. So I think a good start with a lot of questions in this. So we'll continue with our presentations and go on to Akhil's talk. Dr. Akhil Tawari is a spine surgeon here in Bombay, and he will be discussing on classification and surgical approaches for cervical myelopathy.
Should I go ahead and share my screen?
Yes, please, please.
Okay, so is my
No, not yet. We can't see it yet.
is it okay now?
Yep. Go ahead.
All right, perfect. So after an exhaustive talk of Dr. Aaditya, I'll go ahead and take this discussion forward on cervical myelopathy. There are two topics that I'll discuss. One is the classifications and the other one is the approaches. Okay. Now, there are numerous primary classifications that have been developed for cervical myelopathy. The earliest was the Nurix classification system. Then the Japanese, who did a lot of work, came up with the Japanese Orthopaedic Association scale. Benzel et al. Modified the Japanese. And then finally, based on the Oswestry Disability Index, we came up with the Neck Disability Index. The Nurix was one of the earliest, very simplistic classification. Basically, 5 grades, including grade 0, and looking for whether root signs are there, cord signs are there, and how is the gait, and overall, is the patient employable or not. So very, very simplistic. Then came the Japanese. The Japanese were more exhaustive. So they went into detail with regards to the motor functions, the sensory functions, the trunk balance, as well as the bladder and bowel dysfunction. And what they did is they gave a scoring to this. So total score was around 17 for the Japanese. Benzel et al. Modified the Japanese. They gave more weightage to the motor components. They took away some weightage from the sensory component. and they increased the total score to 18. And then they went ahead and again classified this. So if the scoring is more than 15, that means the patient has mild symptoms. If it is between 12 to 15, then it is moderate. And if it is less than 12, then it is severe. Modified, that is the MJOA as we call them, is one of the most widely used scoring system right now. And finally, based on the Oswestry Disability Index, the neck pain and disability index was formulated. It is more like a nomogram in which, based on the pain as well as the ability to perform day-to-day activities, a scoring system is done. And again, if the score is between 0 to 4, then it is no disability. And if it is more than 35 to 50, that means the patient is severely disabled, or rather completely disabled. There are also secondary pointers or scoring systems which have been developed. These are more generalistic in nature, and these are the pain rating scales for the neck as well as the arm and shoulder. The SF36, which stands for the short form 36, the EQ5Ds, which is the European version similar to the SF36. Similarly, if the patient has myelopathic hands, then grip strength, quick dash is used. If there is neurological issues, then the American Spinal Injury Association sensory score or motor score is used. It is important to know because these scoring systems are quite heterogeneous, and in the literature, we may see that multiple scoring systems are used also to communicate and also correlate the functional outcomes based on what approach has been taken. So this finishes the first part. And currently, I think from cervical myelopathy, we should definitely be aware of the modified Japanese Orthopaedic Association scale. Now, the second part of my talk is on the approaches. And of course, we will be talking about the surgical approaches. This is an important slide on why surgery most of the time is inevitable in cervical myelopathy. So we can see that there are three graphs, and in all the graphs, either it is deteriorating rapidly or in a stepladder manner or quite slowly. I like to give a historical background on the approaches. So the gentleman on the left is Dr. Charles Ellsberg. He first described the posterior cervical laminectomy way back in 1925. Between 1930 to 1950s, it was the workhorse. And as a matter of fact, they used to routinely open the dura and see individual nerves, and also like to go in the front and remove all the osteophytes, something that we don't do right now. In the 1950s, the anterior cervical approaches were described. 1970s, the Japanese came with the laminoplasty approaches. In the 1990s, there were refinement in the posterior cervical instrumentation, starting with Dr. Goel and Harm's plate system, and then Dr. Jürgen Harm came up with the lateral mass and the cervical pedicle screws. Now, objective of any approach for degenerative cervical myelopathy is to attain surgical decompression. That is the most important aspect, to restore lordosis and stabilization if necessary. Based on this, the approaches again have to be tailor-made depending upon how many stenotic levels are there. What is the sagittal alignment or profile? Does the patient have good lordosis or kyphosis? Does the patient desire motion to be there, or motion can be sacrificed? And if the patient has some comorbidities in the form of dysphagia, kidney issues, or osteoporosis. These are two important things that we like to consider when offering what approach to what patient. So the K line initially was described on a plain radiograph. It is basically a line which is joining the midpoint of C2 and C7, and was described originally for OPLL. So they came up with two classification: K plus if the OPLL mass doesn't go beyond the K line, and K minus if the OPLL mass goes beyond the K line. And the second is the canal occupancy ratio. So we can see that whatever is the osteophyte or the OPLL component, what is the size of it or the ratio of it with regards to the canal size. Now, the surgical procedures depend upon whether we go from the front or the back. Anteriorly, it is the anterior cervical discectomy or corpectomy and fusion. Posteriorly, either a laminectomy and fusion or a laminoplasty. If it is severe disease along with kyphosis, we can go for a combined approach, which is a 360-degree approach, or we can also go for a 540-degree approach. And then sometimes cervical disc arthroplasty is also recommended. So if we broadly classify the anterior and the posterior, if we go for motion preserving, for the anterior, it is a cervical disc arthroplasty. And for the posterior, it is laminoplasty and laminectomy. Laminectomy is losing its ground, simple laminectomy, because there are chances of post-laminectomy kyphosis. And usually, if laminectomy is done, it is a good idea to supplement it with a fusion. If we go for motion sacrificing, then from the front, either it can be an anterior cervical discectomy and fusion or an anterior cervical corpectomy and fusion. Irrespective of whatever is chosen, we routinely use intraoperative neuromonitoring and a good anesthesia support. We don't want the anesthetist to be overzealous and give us hypotensive anesthesia beyond a point, because the cord is thick and we may end up injuring the cord. Now, coming to anterior decompression and fusion, it is usually for cases which are single or two-level diseases. Tailor-made if there is a fixed cervical kyphosis of more than 10 degrees. It is also recommended if it is K negative, that means the OPLL mass is going beyond the line, and if the canal occupancy ratio is more than 60%. Also good for soft disc or when the pathology is primarily anterior. The approach is the standard Smith-Robinson anterior approach, a workhorse for us for doing any type of procedures from the front. Irrespective of whatever is chosen, either a discectomy or a corpectomy, we are able to achieve good kyphosis correction. We are able to achieve a thorough anterior decompression. So the cord should be seen from side to side. With comparison to posterior approaches, anterior approach has low infection rate, less blood loss, and less postoperative pain. The cons are that sometimes it can take much longer. Also, because these, if we are going for a motion sacrificing, then we usually like to supplement it with fixation in the form of anterior instrumentation. Either we can go for a corpectomy or a discectomy, or sometimes a hybrid construct can also be given. However, it has to be noted that if we are going for an anterior instrumentation, it has been shown that if it is more than 3 levels, then there are chances of catastrophic failure to the tune of more than 70%. Coming to the posterior, one of the workhorses for a lot of us, usually for multi-level compression. However, the kyphosis should be less than 10 degrees. Beauty of this approach is that we can do easily extensile approach. So if you want to go beyond into the thoracic spine, we can do it. If you want to go superiorly into the occiput, we can still do it. There are limitations. So if the kyphosis is more than 10 degrees, we can see that there is bow-stringing effect, which means even after performing a laminectomy or doing a decompression, we may not be able to completely decompress the cord. Hence, it is not recommended if there is a kyphosis of more than 10 degrees or which is fixed. Coming to laminoplasty, very well documented and popularized by the Japanese. It is a motion preserving. Usually, we go from C3 to C6. 2 techniques have been described, either a single open door or a French double door technique. Essentially, we increase the size of the canal and then we like to fix it by using mini plates or sutures. Contraindications are because it is motion preserving, there is no fusion, and hence if the patient has significant neck pain, usually not a good idea to offer laminoplasty. Also, fixed kyphosis can lead to bow-stringing effect. Now, there are certain cases in which we have to go from the front as well as from the back, especially if there is a rigid kyphotic spine. So multi-level anterior cervical corpectomies can be done. Along with that, posteriorly, we like to do a decompression and instrumentation fusion. Also, combined surgeries is the only way out for post-laminectomy kyphosis. So to summarize, anterior approach for a degenerative cervical myelopathy, if there is pre-existing kyphosis, if there is OPLL, which is K minus, or if it is K plus, but the canal occupancy ratio is more than 60%. Posterior approach, if it is multi-level pathology, especially if the patient has severe osteoporosis, renal failure, and smokers, because anterior instrumentation is known to fail in such patients. If the patient has OPLL, then it has to be K line plus, and the canal occupancy ratio should be less than 50 to 60%. Anterior approach has a lot of pros, direct approach to pathologies for the front, and better for those with pre-existing cervical kyphosis. Posterior approach is simpler, extensile, faster, and there is virtually no damage that can happen to the vital structures in the neck. Both of them, they have their own set of complications, which I'm sure would be covered in the subsequent lecture. Now, this is a good chart which will help us to guide what to choose when. So if it is less than 3 levels, primary pathology is the front, better to go from the front. We do either an ACDF or an ACCF. If it is K-line plus, then we can also offer the patient laminoplasty and give a motion preserving surgery. However, for multi-levels, more than 3 levels, for a K-line plus, laminoplasty can be done, but for a K-line minus, we see whether the kyphosis is flexible, and if it is flexible, we can do posterior and then offer laminectomy and fusion. However, if it is rigid, then it is better to go for a combined anterior plus posterior approach. Thank you.
Thank you, Akhil. Nice talk. I think you've covered a lot of questions which I would have asked you regarding the advantages and disadvantages of anterior versus posterior approaches. So you covered it in your talk. But I had some, disagreement regarding your points on OPLL. And I'd like to ask you, and then we can take it to the other panelists as well. Okay, you have said that in 1 or 2 level affection with OPLL, it is better to go in front as compared to behind. Do you stand by it, and do you think there are problems associated with that?
Yeah, absolutely. So actually, I didn't have the chance to defend my the complications. I think Mazda is covering it. So as per the literature and the amount of cord shift that happens while doing posteriorly, if the OPLL is going beyond the K line, then the posterior canal drift of the spinal cord that we anticipate doesn't happen. We are kind of hand pressed to go in the front. Doing an OPLL surgery from the front is not fun. It can lead to a lot of complications, including dural tear. And the only way out probably is the floating bone technique, in which we leave out a piece.
That I agree with you. If it is K-line positive, that is a separate issue. But so do you want to generalize it for all patients of OPLL with only 1 level or 2 level affections go from the front?
So this is the recommendation. OPLL, if we are having a good lordosis, I would preferable first like to see if I can do posterior or not. That will always be how I would proceed. Only if there are some contraindications for the posterior, or I am hand pressed, then I would like to go for anterior.
Okay. Dr. Chaubey, sir, OPLL
Yeah,
cases.
what I prefer, anytime when there is an OPLL, multi-level OPLL, I will prefer to do the posterior first. I will give a breathing space to the cord. Okay. Breathing space to the cord means because there is am I audible or not?
You are audible, sir. You are audible.
So once I do the posterior decompression, the cord has a safety margin. And If I feel that this posterior job is not adequate enough, then in a second stage, I go anterior and do the anterior job. Because keeping the lamina,
what do you feel for our audience going anterior in OPLL? What are you worried about?
I'm worried about sometimes the OPLL can be adherent to the dura.
Okay.
And I can do the dural damage. And in the process, the cord may trip. But if I have already done the laminectomy and done the lateral mass fixation, at least there is a space around the cord. And when I'm doing the anterior job, it is more safer from the neurology point of view.
Yeah, Aditya, you wanted to add something?
Yeah, so basically in such scenarios, usually during pre-op counseling, I tell patient that I'm going from behind. I'm going to do the decompression job and will observe you over a period of 3 months, because most of the times that is the sufficient time how they have responded to the surgery, whether clinically they are getting better. So I tell them that in 3 months' time, if you are doing well, you are improving day by day with post-op physio and everything, then there is no question of going anterior. But let's say after 3 months also, if you are not getting benefited or the desired effect of surgery, if it's not seen, then maybe we may think of anterior job maybe 3 or 4 months down the line. So this is part of pre-op counseling. So usually I don't give that option at first instance. But during my pre-op counseling, I tell this fact to them.
That's an interesting way of doing things. You can do
only thing what I differ a little bit, I do not give a time frame to them.
Okay.
I just do the posterior decompression. I judge the patient, and I go as per the how much the patient has the spasticity, how much is the weakness, whether the functional level of neurology or the non-functional level of the neurology. I also have to make up my mind when to go.
Yeah, normally it's like that. Okay, we know what we have to do, and
so
we
that
don't really
I will not give the time frame. I will wait for 3 months. I will wait for 2 months.
So
but whenever necessary, we can go for the anterior surgery. That is how I convey. First, I'm doing the posterior surgery, and we may have to go and do the anterior surgery whenever needed.
So by default, in my posterior cervical patients, I always carry out post-op MRI at 4 months and at 1 year by default. So
it's not the question of just doing the decompression part. But if suppose there is a large bump from the front, so we know that probably the motor recovery or the spasticity reduction may not take place in due course of time, only by doing the posterior surgery. So we have to make up our mind depending upon the overall clinical scenario.
So is there any, I'd like to ask Mazda also to come in on this. Do you want to get any investigations done, or before you decide, no, I want to do this from the front as well? Aren't you worried about causing more injury if the OPLL is stuck down to the dura, which it often is? Yeah, Mazda?
I mean, besides the CT scan, I don't see any other investigation that's available to identify how much ever the dura is stuck. But how much ever it is stuck, if you're doing it anteriorly, you're still able to drill it down in most cases comfortably to a point where you can feel the dura soft over it, even if you leave behind a sliver. So I don't feel, I also personally feel it's a lot to do with your training, wherein which if you've been exposed to doing the anterior approach, which neurosurgeons, and I'm not trying to bring in any discrepancy between neurosurgeons and orthopedics or any of that sort, but I'm just trying to say that we were trained a lot to do anterior approaches from the when the pathology is anterior, address it from the front. That was the conventional teaching. And by no doubt will I say that if there's a 4-level OPLL, I'm going to go in from the front. But if there is a very sharp focal indentation or a very sharp OPLL from the front that is causing a focal anterior stenosis, yes, then I don't think it is prudent to go decompress C3 to C7 from behind. And one would still go from the front as much as is possible to try and drill it out or thin it out. So it's very difficult to make a broad statement saying that
Case
we'll
specific.
do, or it has to be very case specific. But if it's a focal OPLL, I tend to agree with Akhil that there is a tendency to address it from the front. Yes, Aditya has a point of view.
So this is not about particularly OPLL. It's about sometimes we do see focal kyphosis. So maybe at C5, C6 or C4, 5 level, there is just focal kyphosis, but there is overall lordosis. So there is a beautiful paper by Dr. Bhojraj in 2017 in Asian Spine Journal, where he classified these curvatures, and in type C2, which is a focal kyphotic degenerative cervical spine with myelopathy. So he's still advised to go posteriorly to do laminectomy in such scenario, because what he's saying that because of the overall lordosis, there is boosting effect. So even if you do a laminectomy, even though there is focal kyphosis in the center, but from C2 to C7, there is generalized lordosis is still intact. Still, you can get away by just doing posterior job without doing any anterior.
Yeah, so carrying this ahead, there's a question from Dr. Tosfik about Dr. Bhojraj's classification on cervical myelopathies. Can you elaborate on that?
So it's a beautiful paper in Asian Spine Journal. It's readily available on net also. So it's classified into 4 types. So type A is one level anterior compression. So it's purely disc, which is the main pathology over here, which is type A. Type B is 2 levels of anterior compression. So anterior compression, but 2 levels. It's type B. Then now we'll come to type C, which he has subclassified into C1, C2, and C3. So C1 is complete kyphotic curve. So where the cervical degenerative spine is completely kyphotic. So it's more than 3 levels. So this is type C1. Type C2 is segmental kyphosis with overall lordosis, what I was talking about. So if you see right from C2 to C7, there is generalized lordosis, but you may see in the center of in the center there is
curve that there may be a
local kyphosis. So that is type C2. Type C3 is complete lordosis, which is usual what we see in cervical spine. And type D is basically a posterior compression. So there is purely only posterior compression. So that is type D. So according to that, he has proposed which surgery, whether you have to go from front or behind.
Front or back,
yeah,
or combined. Yeah. Thank you, Aditya. So we'll go on.
Sorry,
Yeah, Mazda.
What is the condition that you would go from the front? There must be a very limited role.
So it's only type A and B, where there is 1 level anterior compression or 2 level anterior compression. So, and obviously,
whether it's OPLL or
OPLL, and obviously type C1 also, where there is generalized kyphosis. So those cases, obviously, you won't be going from behind.
Again, case specific, generalized kyphosis, maybe you would want a combined as well. So, I mean,
maybe, yeah. Absolutely.
Can I make a quick comment on this?
Yes.
Okay, so first of all, the OPLLs that right now we see in practice, we don't see somebody which is K negative very often. Most of the times it is picked up quite soon and we are able to tackle it from the back. If there is I would still consider that if there is a focal kyphosis only at 1 or 2 levels, it is easier to do the surgery from the front rather than subjecting the patient to do a complete job from the back. So I would rather go from the front for a focal kyphosis.
Thank you.
Yeah, you may do from the back, but probably, that would be more.
So we'll go ahead. We'll have some more discussions when the cases come along as well. We'll go on to our next talk by Dr. Mazda Turel, who will be talking about complications and prognosis of cervical spine myelopathy. Please go ahead, Mazda. Please share your screen. So this is an important talk on how you have to talk to the patients in the
Participant can
counseling
now
part.
see your application. You are screen sharing. You have started screen share.
Sorry, I don't know where that is.
Yeah, go for it. Go.
So basically, we are going to try and summarize what we've learned in the past two talks with understanding what the complications of cervical myelopathy and the outcomes. So first and foremost, there's complications regarding the diagnosis. As Aditya said, that these patients can
Get up
present
from the chair, lean for
with a multitude of problems. So this is a 71-year-old man who's come with difficulty in gait. And I would like for you to make a diagnosis looking at him. This gentleman you can see that he's got a shuffling gait. He's walking slightly difficult. You can see there's a little bit of a tremor in his hand. And he was diagnosed to have atypical Parkinson's, but not by a general physician, not by anybody, but by a proper neurologist. And an MRI brain was asked for. And he was started on medication for Parkinson's, and he continued to get worse on Parkinson's medication. And when he came to us, we examined him, and he had spasticity in his upper limbs and lower limbs. He had not upper limbs so much so, but more so in the lower limbs. Upper limbs were actually relatively normal. And he had exaggerated reflexes with upgoing planters. So, and he had no upper limb symptoms. And you can see this is his MRI. He has what we call a classical multi-segmental OPLL, multi-segmental focal OPLL with significant stenosis. But like I told you, he had no upper limb symptoms at all. It would actually be interesting, if we had this as an audience poll to see what every person would do. And there's so much of variance in what each person would attempt to do. He had this calcification of the posterior longitudinal ligament at C7T1, T1. And that's all we did for him. We I told him this is not Parkinson's. We removed this. You can see this focal thickened calcified ligament that was pressing on the nerve at C7T1. We didn't address any of the pathology in the upper cervical spine because he had no upper limb symptoms. And you can see that this is his gait before surgery. And this was his gait after about 3 months of having had the operation. And still now he's on about 4 years follow-up and has no upper limb symptoms. And we haven't touched his upper cervical spine. You can see he's attempting to tandem walk. He's not wobbly. He's attempting to tandem walk, and that also he can do fairly comfortably compared to what his gait was. So the first problem in patients with cervical myelopathy are complications related to the diagnosis itself. And that's why a very thorough clinical assessment and evaluation is important, because gait disturbances may mimic Parkinson's, may mimic atypical Parkinson's, may have features of normal pressure hydrocephalus. So patients should also, if patients have gait disturbances with urinary problems and memory impairment, which is the triad of normal pressure hydrocephalus, should be evaluated for a brain scan, because these patients can present like a typical cervical myelopathy, but may not have much of a compression on the cervical spine, but all their symptoms may be due to enlarged ventricles in the brain. So a thorough neurological assessment and evaluation is very important to stay out of complications, because first of all, you don't want to do a wrong operation for a patient. And that is why I usually like to write about these articles. I write a fortnightly column in the Sunday Midday to talk about these particular scenarios. Now, once we've at least made the diagnosis of cervical myelopathy, and we've confirmed that there is compression of the cervical spine and nothing else which is causing this patient's symptoms, we have to decide on the choice of approach. And like we've discussed previously, what are the conditions in which one would choose an anterior approach as opposed to a posterior approach? Now, this patient, you can see, has significant compression in the cervical spine from the front and a little bit from the back, but primarily this is an OPLL. And again, there will be a debate as to how people would approach this, but this patient was operated elsewhere and underwent a C3 to C7 corpectomy, a standalone corpectomy with a mesh cage. That's it. This is what was done for this patient. I would disagree that this is the correct option to be given to this patient. Post-operatively, this patient developed a complete paraplegia with a upper limb weakness. So a paraplegia with upper limb power as 3/5. And he was told that there's nothing else that can be done. This is probably a hyperperfusion injury. And this was the post-op MRI done by the hospital somewhere else. And you can see that there is obviously still very, very significant residual compression. This is the post-operative CT scan done. The OPLL has not even been addressed. So we said that the only hope for him, in my opinion, is to do a posterior approach and do a laminectomy and fusion. I didn't want to address anything from the front because it's tormenting. And we did a cervical laminectomy all the way down to T2 with a fusion. And over the next 4 to 6 weeks, his upper limb power improved to completely normal. And the lower limb power has improved from grade 0 to grade 3 in a period of 1.5 months. One may argue that if there's damage to the spinal cord, this may improve on its own. But I believe that relieving compression is also a key factor. Some people believe that instability in such cases is the nodal point of the disease, and that should be addressed. So we addressed both. We can discuss these cases later, whether anything else should be done differently. So where I studied, we did in Vellore, we did close to 500 anterior cervical corpectomies for the anterior approach. By and large, today, in today's day and age, a single level or a 2-level discectomy should almost have 0 to none complications. Barring a mild dysphagia that happens for 1 or 2 days post-op for almost everybody. And that some people say can be minimized by reducing the cuff pressure of the tube during the operation. But very rarely do these surgeries go on beyond an hour and a half to warrant that kind of intervention. The common complications of the anterior approach are C5 palsy, recurrent laryngeal nerve injury if you're operating at C6, C7. And the way to prevent that, most people say, is to use the approach from the left side instead of the right side, and where you don't encounter the recurrent laryngeal nerve. So that might be a good trick to use to prevent that. Dysphagia, in my experience and that of others, has been found to be present in almost everybody for the first 1 or 2 days. Have some, you may not call it dysphagia, but everybody has some a little difficulty in swallowing, but that almost completely resolves in a couple of days, and very rare is it to be present beyond a long-term period. Dural tear is also, as you can see over here, in the range of about 2.5%, and it increases in the presence of multi-level corpectomies or discectomies instead of doing it at a single level. Hematoma at the operative site is a freaky complication and doesn't happen. It happens extremely rarely. This is a series where a corpectomy was done with a iliac bone graft, but nowadays nobody uses that as a standalone procedure. Most often people use either a mesh cage and plate it from the front or directly an expandable cage. Surgical site infections are also exceedingly rare in the anterior approach and quite common in the posterior approach. What is common in the anterior approach is airway edema, especially if you do surgery at C2-3 or C3-4. It's very important that you look at the airway edema if people have sometimes difficulty in breathing, sometimes a hoarseness of voice also may be related to airway edema, and you should keep a close watch on that on the X-ray. And airway edema is known. We've studied airway edema with serial radiographs on day 1, 3, 5, and 7 after anterior surgical approaches, and it tends to peak at from day 3 to 5 and then subsides. So if patients begin to don't have symptoms on the first 1 or 2 days, they may have symptoms on the 3rd to 5th day, and in that particular time period, a short course of steroids, preferably dexamethasone, which is slightly long acting, also helps a great deal. So those are the things that need to be considered as far as airway edema is concerned. And a large series across North America of over 260,000 patients, their reintubation rates were about 5 every 1,000. Also, you can see how the airway edema is over here. Normally, edema, if you measure the airway edema in front of C2, the esophageal thickness should be about 6 millimeters, and in front of C6, it should be about 20 millimeters. Anything more than that can significantly compromise the airway. And the risk factors for airway edema from the anterior approach is more than a 3-level lesion, corpectomy, especially elderly people, if you've had a long surgery and if you've operated at the upper cervical level. And then there is the long-term complication of pseudoarthrosis. The results of a single-level fusion are the best. Even single-level fusions don't have a 100% fusion rate. That rate varies from about 95%. As you increase the number of levels and as you use substitutes that are not elemental to the normal bone, the rates of pseudoarthrosis increase, and the rates of pseudoarthrosis are up to the range of 40 to 50% when you do a 4 or a 5 level ACDF. It just depends on whether these rates are symptomatic or asymptomatic, and the risk factors include obviously multiple levels, smoking, steroids, and using more metal. What are the complications of a posterior approach? So the two dreaded complications of a posterior approach are a C5 palsy and quadriparesis. So a C5 palsy happens in about 5 to 15% of people following a posterior approach, and a large study has found that the width of the laminectomy doesn't really make a difference. There are a lot of data and a lot of hypothesis why the C5 palsy happens, whether it's at the apex of the curve, whether the C5 root is a little less sensitive to strain, whether it takes a longer course as it exits the foramen. But one consistently found feature in C5 palsy in a study that we had done is that there is an extensive degree of foraminal stenosis in those patients who have C5 palsy. So if you're doing a posterior approach, if you're doing a standard C3 to 6 laminectomy with fusion, please always make it a point to do a foraminotomy bilaterally at C5. And that has shown to reduce the incidence of C5 palsy. If you do a foraminotomy at C5, you see the root exiting out, and these patients tend to have foraminal stenosis at that level because it does form at the apex of the decompression. So you have to relieve that stenosis to reduce C5 palsy, but the width of the laminectomy is not associated with C5 palsy. Some people say that the width, for an anterior approach, the width of the corpectomy should not be more than 16 millimeters. That also, so that some people have said that tends to increase the chance of a C5 palsy when you're doing an anterior approach. The dreaded complication via laminectomy, and I'm sure if we've done enough, all of us at some point have had, if not a quadriplegia, at least a quadriparesis following this. And what I insist uh, in every patient with severe stenosis of the cervical spine, I always have an arterial line for these patients and always keep the mean arterial pressure above 95. Whatever the baseline pressure of this patient is. And that has always worked. And this study shows that even patients who...
Dr. Satyen, Mehta to me. Bit quicker, please.
Okay, fine. These patients also have shown to get better if you maintain the mean arterial pressure. And a delayed complication of the posterior approach is post-laminectomy kyphosis, and that is why almost everybody who is young, at least, has a laminectomy for whatever reason they do, should have a fusion done. And sometimes these patients deteriorate over a long-term period after a laminectomy. They develop myelopathic features, and that may be related to the bowstringing of the cord, and it may require a fusion and a correction. Complications related to the wound. This patient is also something that you must not neglect, and complications related to posteriorly are more important. Anteriorly, you almost never have any complications. This patient had a traumatic quadriparesis, and you can see he's got multiple fractures behind. He underwent a C3 to C6 laminectomy and fusion, but post-operatively he had soakage of the wound consistently. It was not CSF, it was just blood clots coming out of the wound. We washed the wound out again and discharged him, but he has readmitted with persistent ooze from the wound. And here you can see while we're checking his wound, there's just persistent blood coming out of the wound, despite of having it washed out. And even without really pressing it, it used to come out. So we did an angiogram to see what's happened, and we found that there's a pseudo aneurysm of the branch of a deep cervical artery, and probably one of our screws in the lateral mass is touching that branch, and it formed a pseudo aneurysm. We embolized it and then washed the wound out, and that stopped the leak. So if you have a bloody discharge from a wound, if you have infection, etc., it's okay. We've all understood how to deal with it. But if you have a bloody discharge from the wound, then please make sure to do an angiogram. Sometimes you may even have a vertebral artery aneurysm. Now the prognosis, I'm going to quickly go through it, but more than 70 to 80% of people improve after any anterior or posterior decompression following a cervical myelopathy. And there are there's a lot of talk about T2 weighted intramedullary signal changes, and a high intensity on the T2 weighted change and a low intensity on the T1 image.
Dr. Aaditya, Kashikar to everyone. Great point. Bloody discharge. Think of vascular complication.
Results in the... So a high frequency intensity on T2 presents. So we also spoke about how post-operative changes evolve and whether they actually correlate with... So we classify these signal intensity changes as fuzzy, sharp, and mixed. And here you can see this is a patient who has a very focal OPLL. And like we were discussing, we went in from the front and did a corpectomy to show, and a patient improved clinically, and these signal changes eventually sometimes resolve. But when they, at long-term follow-up, when they become sharp, the one should understand that the clinical benefit or the clinical improvement probably stops at that level. Sometimes You can even see after anterior decompression have signal changes extend beyond what you thought was normal. But if they don't have any clinical deterioration, you see over time that these changes really get better. So to end, if you want to prevent complications for any approach, anterior or posterior, keep the head as neutral as possible. That's the key. Even in anterior cervical spine surgery, you don't need to extend it a great deal. And posteriorly, obviously, don't flex it too much. Always keep the mean BP above 90. If you want to prevent any complications related to dysphagia, airway edema, etc., while the anterior, do a nice extensive subplatysmal dissection. However small or tiny your incision is, that's perfectly all right, but make sure you do a nice subplatysmal dissection, and that avoids complications with the anterior approach. And avoiding complication with the posterior approach, primarily a C5 policy, you should do a foraminotomy at C5. That's about it. Thank you.
Thank you, Mazda. So you've covered a lot of these complications and all, which are all very important points. But I wanted to go on counseling. So in fact, I'd asked Dr. Chaubey to bring forth his points on this. Okay, how do you counsel these patients of cervical myelopathy about their treatment, about their surgery, and what to expect out of it?
Suppose if I planned for the posterior decompression only, then most of the time, actually, it is a natural progression of recovery. So the counseling wise, we say that every month I'm going to see you and you'll see how you are progressing. And if there is any disturbance, we will see to it what is the most appropriately to be done. If we are going to do the anterior surgery, then all such things like the recurrent laryngeal nerve palsy or the deglutition problem or the sometimes the wound related infection related issue, the hardware related issue, all such things we explain in detail in a pre-surgery school kind of a thing, and then we go ahead.
Sir, this patient, when they come and ask you, sir, now I've got difficulty in walking. After surgery, मैं normal चल पाऊंगा ना? मुझे खेलना है, मुझे भाग दौड़ करनी है, कहना है, मैं सब कर पाऊंगा क्या नहीं?
You never give a rosy picture. You always tell the patient that what I'm expecting, you should be better than what you are.
कितना better होगा sir?
That there is nothing like a percentage. I never have uttered this word percentage. You will slowly, gradually, you improve depending upon the potential what you have in your cord.
Sir, मैं बहुत मेहनत करूंगा. मैं 2 महीने में रन कर सकता हूँ sir.
I will say, I don't know the recovery pattern. I only know that you are going to be better than what you are.
तो हो जाए 2 महीना नहीं 3 महीने में हो जाएगा sir.
I never give a time frame. Never ever give a time frame. At least in the cervical.
But हो जाएगा ना sir. भाग पाऊंगा ना sir.
I say कि whatever is recoverable, it will recover. Whatever is not recoverable, it will not recover. And we are doing the surgery to prevent the further deterioration. Whatever you recover is the bonus.
Correct, sir.
Excellent,
I
sir.
think
Excellent point,
these are
sir.
golden words. And Dr. Satyen was behaving like a typical patient.
Yeah, great job, Satyen, sir.
Yeah. And so you did not give in. You stuck to your guns there. Okay, yeah, we have to tell them that it is to prevent further complications and further deterioration and basically. But sir, operation के बाद आगे कभी तकलीफ नहीं होगी ना फिर? जितना है उससे खराब नहीं होगा ना?
हाँ, जितना है उससे खराब नहीं होगा. That I try to emphasize and I see to it कि he should not deteriorate only by doing my surgery. And somehow like this post laminectomy kyphosis, this C5 palsy, I may be fortunate, but I don't see a lot of them because even if suppose
we don't see a lot of C5 palsies.
I don't know because you see the C5 foraminal decompression is part of my laminectomy.
Okay.
Each and every
Actually,
patient.
sir, it is so common that I was discussing with Kshitij the other day, and he said he counsels them about all his patients in posterior decompressions that you will get C5 palsy. After, it will not happen immediately. It will happen 2 to 3 weeks after the surgery, and you will not be able to lift your hand. And then after a few weeks, that will also recover. And the patients come back and say, yes, yes, sir, you had told me कि नहीं उठेगा, अभी नहीं उठ रहा है. उसके बाद
But
exercise
somehow
करके it comes back.
I differ. I never ever say that you will develop the C5 palsy. I may be wrong, but because in these 20-25 years of the cervical spine decompression, I've not seen a single
Not
C5.
yet. Okay.
Not yet. Not yet.
Great, sir. Maybe the cord is not falling back enough to give you
I think we
traction
definitely have to
injury.
visit you, sir, because C5 is really, it's a painful condition to deal
But
for us
but
also.
Painful
somehow I
for the
don't know.
surgeon.
I
To the
don't know.
surgeon, yes.
Yeah, I always do the C5 foraminal decompression in all laminectomy patients and all.
Yes.
I see to
So,
it that I must see the C5 nerve root.
yeah, I hope, sir, law of averages does not catch up. Aditya, yes, please.
Yeah. Mazda, in your experience, have you experienced C5 palsy on day 3 post-op? Because in recent times, just 3 weeks back, I did one usual cervical laminectomy. Patient was typical CSM patient with typical myelopathy symptoms and signs and everything. Uneventful surgery, finished it off in 45 minutes, 1 hour job. Post-op and intra-op also, there was no event, no complication. Day 1, walked very well. Even his imbalance also, he said that I'm walking far more better than before. Day 2 also fine. And day 3, he's started saying कि हाथ उठाने में तकलीफ है. And it's like grade 2 power. Day 3. So have you experienced anything of such thing on day 3 post-op?
And delayed post-operative C5 palsy is a known entity, and that's the reason why some people say that using intraoperative neuromonitoring is of no use because you're not able to
Absolutely.
get up.
Because in CSM as such also signals are not seen in pre-op. Means
So
even
the
if you do intra-op neuromonitoring.
C5 palsy is about 5 to 15% across literature, and the incidence of delayed palsy is in the range of 3 to 5%. So it's common, but and it almost always recovers in a period of 3 to 6 months. That's also what literature says. And again, there's a lot of discussion about why it happens, and there's a lot of enigma about why it happens, but nobody is able to conclusively say what the reason for this is. Stabilizing the cervical spine, some people say, is that may be one of the factors to prevent it, because a focal instability is another cause that people are talking about, being the cause iatrogenic. Now you know that there are people discussing posterior fusion alone without decompression for cervical stenosis. So again, those are controversial things. They're not universally accepted, but if more and more people for a standard laminectomy are tending to fuse rather than leave it alone, and that may be one reason to lower the incidence. But again, this is conjecture and speculation and not foolproof.
Yeah, the most common reason given is that depending on the degree of fallback, if the cord actually falls back, then there is a lot of traction on the C5 root, and that could cause the injury. That's hence it happens late post-operatively.
Yeah, but
So,
same kind of case in 100 people, and let's say 3 people develop the complication. So
yeah,
you're
we don't know.
able to explain what is different in these. I'm sure there must be something related to the anatomy, something related to the microcirculation, something related to oxygenation, blood, all of those combinations that may play a role. But it will be great to be able to pinpoint it because it's an irritating complication.
One comment I want to make regarding your first a few slides about your first case, what you showed, in which patient was diagnosed to have atypical Parkinson's disease. So I want to make one comment over here that I feel neurologist, rapport with your neurologist is very much important. Even, I mean, just like even you yourself can see the difference in the way you are delivering your surgical results, the earlier days of your practice and now what you are doing. You are getting better day by day. So same way, even neurologist also, you have to have good rapport with your neurologist. Be persistent with one or two good neurologists because they also learn from these examples. Like, so if at all they have diagnosed atypical PD and post-surgical, if patient has done well, you should go back and tell that neurologist, boss, this was the thing and I have done this and they got better. So retrospectively, even they can think of this because we have 2, 3 neurologists like, means we have seen them evolving over a period of time, the way they diagnose the spine conditions. So I feel this is very good message I want to make over here.
So I'll go ahead and start sharing my screen and show a couple of cases. And a lot of people actually look forward to the case discussions part. I hope you can see it.
Yeah, we can.
Yeah, is this okay? Can you see the whole thing?
Yeah, we can.
Okay. So feel free to jump in anytime. I'm just getting it ready. So this is a 45-year-old female who came with a lot of gait instability. She had weakness in her grip. Right was worse than left. Low limb spasticity, but bladder bowel is normal, and there's some decrease in power in both low limbs. So what do we have to do at this stage? Does anybody want to jump in? Chaubey sir, is it straightforward for you, or do you want to
If you
get
see any time if there is a gait disturbance, then I will see the reason for the gait disturbance, isn't it? So you do the MRI, see what is the reason of gait instability, because gait disturbance. Nothing else.
Yeah, I'm going ahead. Akhil, this MRI is in front of you. Can you just tell me your findings and what do you think we should be going ahead and doing now?
Correct. So we definitely see there is anterior pathology. This probably looks like a soft disc that has come out and causing cord compression and cord signal changes, primarily at C5, C6 level.
Why do you say it's a soft disc?
Probably, I would have to see all the films actually. Doesn't look like soft actually, but yeah, it's more
So
like a
what's
disc.
the differences between a soft disc and a hard disc?
So you have to see the signal change on the T1 as well. Here it on the T2 actually looks more like a calcified disc ossified complex. Better to, if at all I jump in, I would definitely want to get a CT scan on this patient.
So here
Okay.
the uppermost right side axial cut, on the left side there is one small whitish dot.
Dot, correct.
It can be just acute on chronic disc, maybe, I'm not sure. So the blackish part is the calcified one, but the whitish dot could be the acute disc. I might be wrong.
You see, whether it is acute or chronic, if there is a focal compression, you always do the CT. Even if it looks acute, but it may be chronically, there may be some osteophyte or the calcification which was existing, and the presentation merely is acute.
Yeah.
So it is always.
Why is the CT important at this stage?
CT is important because you are going to do a focal job. You must know whether there is anything which is hard. And if it is hard, you should be ready for that, how to deal with that hardness.
So for planning purposes.
For planning purpose, yes.
Yeah. So Mazda, now this patient number one is you're looking at it, you're thinking it's a hard disk. Is the X-ray of any benefit here? Does that give you any further information or not really?
Very difficult to say so on the scan, on this X-ray, especially because the shoulder seems to be obliterating the level that we are trying to see. But you try and anticipate any kind of focal OPLL. If you are able to zoom in, then it's possible that there could be focal
In fact, I am not able to on this. I'll just go in and show you the CT scan.
Yeah, there
And
is.
this is what the CT scan shows.
It did look like there was an osteophyte
Hmm.
on that, and I
So
thought that
now that you see this, you see that there is osteophyte. Okay, it's probably a hard disc. What are you going to? How does it change? How does your planning change? What are you going to keep ready in OT?
I mean, nothing really changes. We always have a drill. We always have
Okay,
all the
all
equipment
ready.
we need for a case, because I use a drill for every cervical discectomy as well. I drill down the osteophyte posteriorly in all cases. Uh,
Okay.
so there's nothing in addition uh, that we would use. But can you go back to the CT, the decision over here to consider whether you want to do a 2-level ACDF or a 2-level corpectomy?
Yep. Go ahead. Tell what do you want to do. So do you want to do a 2-level ACDF here?
Or a single level? I mean, I was looking at it when the first time I saw it, I thought this would require a C5-6 and a C6-7 ACDF. A C5-6 alone may not have sufficed. But
You can see the axial cuts.
yeah, thinking of it, in hindsight, I would do a single level corpectomy now. And
Which level?
C6, 2, 3, 4,
5,
C6. So by
C6
that,
corpectomy and
that
2-level discectomy.
that the C5-6 and the C6-7 disc.
So you can see the C6-7 lower down is the cut there. Do you
This
think they are significant?
is not significant, but there's compression behind the body of C6.
Body of C6. So there
Maybe
seems to be some compression. I agree.
may not be able
So
to.
Akhil, you would do a corpectomy.
I think I would do a C6 corpectomy for this. There is some disease component behind the body of C6. I would not be able to tease that out by just doing C5, C6, ACDF.
Chaubey sir, do you defer
Corpectomy. Corpectomy.
corpectomy? Akhil,
Yeah, I would go for
sorry,
corpectomy.
Aditya.
So here I would like to do flexion extension X-ray. So if I see any extension on flexion extension X-ray, if I'm able to achieve or see any proper extension on X-ray, then I I will go to posterior approach where I'll do decompression and stabilization. I won't touch, because again, as Mazda said earlier, it all depends on your training also. I am more trained in posterior surgeries than the anterior ones. I am more comfortable in my hands. I can deliver more better job with posterior. So
So I understand what you're saying. And you can see that.
Yeah. But obviously, if at all I am getting lordosis or extension on X-ray, then only. Otherwise, obviously, anterior has to be done. No question in that.
Yeah, I understand what you're saying, but if you can see that the compression is mainly anterior here.
It's a
So that's
focal
of course there is.
compression.
Yeah.
It's a focal compression which is anterior, and the reason is very obvious. So anterior should be the preferred.
Yeah.
Just because
And
it
this
was
patient had a
calcified,
good amount of extension and obviously no instability, but she was able to extend her neck.
okay, maybe my choice would be posterior over here.
Okay. And anything that we want to tell the patient regarding counseling, anything specific?
So in my thing, my first and foremost counseling part will be, though I am going posterior, what I said at the earlier part of the session, that I'll counsel them that though Dr. Chaubey doesn't give any time frame, but usually I give time frame of 3 to 4 months, where I tell them that I'm doing, even though the anterior compression is there with hard calcified OPLL causing the compression, I am going posterior because of certain reasons which we need not disclose that to patient. But posteriorly, I am doing decompression and fixation. If at all clinically, if you are not getting better, then you may require anterior job 3 months down the line.
Yeah, I completely understand it. But normally when I see these, see the degree of OPLL, and if it's not too bad, then I think it's fine. Anterior should be quite okay in this case.
I'm not denying the fact that anterior is wrong here. Anterior is the first preferred option.
But there's a different way of skinning the cat.
I'm just it's all about the training part and the comfort.
Yeah.
Nothing
else. It's fine. Yeah, Akhil.
I think more often than not with this kind of focal disease anteriorly, more often we will go for anterior approach. I don't think posterior for any other reason apart from training.
I'll just go ahead. That for this patient, I thought that the complete problem is coming from the disc in front at C5-6 level, and you can see the cord compression. All the changes are at that level only. There's a good amount of CSF above it, and below it as well. I did not see that there was a significant amount of compression or any cord changes. So I went ahead and did a single level ACDF for this patient. I tried to put up a slightly biggish cage to give it a little more space, and a patient did quite well and with least amount of morbidity, and so the patient was able to get up and get out quickly, and neurologically also improved. And she had much better improvement than what I counseled her for.
So
any comments?
Was it hard or intra? What was the thing you got over?
Yeah, it was hard. It was hard, and I had to
everything.
Yeah, I had to drill it out. I don't even need that. I just use a small curette and gradually scrape it out. And once I get an opening on one side, then I can put in a number 1 kerosene and gradually take out the rest of it. And it comes out quite easily, especially if you give it a little good distraction, then it all comes out easily. Anything, or should I go ahead?
You were lucky because many times this focal compression is very much adherent to the dura, and if you have a very limited space, you may not be able to take that out.
Yes. So that's also a good point. So we had kept everything ready in this patient along with the plate and our cylindrical mesh cages. In case you're not able to get it out, then corpectomy is always an option available. So all that was always kept ready in these cases, but we were able to get away with this quite nicely. I was quite happy with the amount of decompression with my probe going all around it. So I was okay with it. Yeah, I'll go ahead with the next case. So this patient has come now, Aditya, for you. 51-year-old male. He came with neck pain, bilateral trapeziitis, and he's otherwise okay. He's walking okay. He has got, but on examination, he has got some exaggerated reflexes. Otherwise, walking fine. This is what his MRI looks like, and you can see that there is OPLL developing and decent amount of cord compression behind the C6 with cord changes. What do you do at this stage?
So I see over here the OPLL part is right from C4 down up to upper part of C7. If you see predominantly behind C6 body, but almost 2 disc levels are involved over here. Again, posterior is the way to go for me over here. Okay, I would have done here standard C3 to C7 laminectomy. What is the age? 51. So maybe fusion along with that.
Mazda, do you want to?
When you say trapeziitis, neck pain.
So he came with neck pain with pain shooting down the trapezius, shoulder pain.
It's not managed conservatively with anything. I would not.
He's been getting pain. Yeah, he's been getting pain. Painkillers are on, but he still has that.
I mean, my indication for doing a laminectomy is the patient should have clinical features of a myelopathy. I know DTR is mildly exaggerated, which is not a clinical, has to have 2 long tract signs.
But Mazda, see the cord, it's so bad.
If you permit me to show you one case, I know it's on this thing, but I want to show you this for the benefit. If you allow me to just show one image, I know you are saying the cord is so bad, but allow me to show you just
Yeah,
one.
I'm trying to extract an answer from you.
No. Just listen. So if the patient doesn't have myelopathy,
Yeah,
I would not suggest surgery. If the patient has no difficulty in walking, no upper limb symptoms, neck pain, uh, I would. Am I able to share my screen?
yeah.
Once.
Hold on. If you want, I'll stop sharing. Hold on.
Dr. Satyen
Yeah,
Mehta has stopped screen share.
you go ahead and share. Yes.
Sorry, this is my point that I want to make.
Yeah.
Uh,
Participants can now see your application.
Can you see
You are
this
screen
patient?
sharing. You
This
have
patient
started screen share.
has an ossified anterior longitudinal ligament, and this is his CT scan. Okay, this patient was operated for a meningioma in the head, which is when we diagnose this. He has some on and off neck pain, and no real symptoms except for exactly what you said, mild exaggerated reflexes. And this is his spinal
Yeah.
cord. It's 10 times worse than the scan that you are showing.
Hmm.
For the last 4 years, he's been on follow-up with absolutely no further symptomatic no symptoms apart from on and off mild neck pain. Would you operate on this?
No.
I mean, yours is an easier decision to make because at the most it needs a laminectomy and a fusion. But I'm saying, just to play devil's advocate, everybody is looking at the scan. There is compression, there is edema. The general tendency is to say surgery. But if you have only neck pain, do we do a laminectomy and fusion for neck pain? Is the honest question
Yeah.
answered?
So basically, I thought Dr. Satyen was asking what surgery you will perform. That's the reason I gave the answer. I'm not changing my answer again. So surgery wise, if at all we have to operate, then posterior what I'll go. But what
Yeah.
you rightly said, just for neck pain, even I won't operate on this patient. I need to have proper clinical symptomatic picture of myelopathy, sign-wise myelopathy signs, then only I will offer them surgery. But if at all we have to do surgery again and again, I'll talk to patient. Sometimes patient's work profile also matters. So if this patient is having any heavy physical job or anything like that, or chances of whether he's traveling daily on a regular basis, long distances, where it's like cord is at risk. So sudden jerk or so something like that. So I will talk to patient, give them all these scenarios that you have MRI picture, which is surgical, but symptoms wise, clinical scenario wise, you doesn't require any surgery. So it's like you have to take a call. If you feel you don't want लटकती तलवार रखनी नहीं है तो सर्जरी कर सकते हैं. But if given a choice, I won't operate on you. Observe yourself. I counsel him for red flag symptoms. If you develop any of those red flag symptoms, then only we'll operate.
Yeah. Thank you.
If I may, so I think
Satyen, can I add a point here?
Yes, please.
Whenever you see the cord edema, okay, DTR breast, patient has a neck pain. So what generally I do, if there is no motor deficit and the patient is comfortable, I give a Philadelphia collar and I give a doses of steroid, means for at least 3 weeks. I give the steroid and I do the MRI again after 3 weeks. And I again clinically reevaluate the patient. And I have seen that the patient has improved clinically as well as the MRI picture has also improved. And we could, in that particular scenario, we have deferred surgery for the long time, not for the short time.
Thank you, Akhil. Go ahead before we.
Yeah, I just wanted to say that I think as Aaditya mentioned, counseling for red flags and timely follow-ups, I think that is the key. Because more with considering the natural history, 95% patients develop some neurological issues.
Yeah. So
With
I agree
cervical
with you. Actually, this case was just brought up to bring forth the point that we are going to treat the patient and not the MRI.
Correct.
And
Correct.
very often you see MRI findings, but if the patient does not have any clinical signs and symptoms, you don't want to touch them. We can counsel them and follow up with them at a later stage and only intervene if they do develop any symptoms. So before I go ahead, Mazda, you wanted to add something here?
I'm saying if you really want to operate, you can use the cardiologist's approach, which they use for putting a stent, saying that, you know, if you have a trivial trauma, you're going to become quadriplegic.
Yeah, no, I do not want to operate.
You
Yeah.
know, and fear, I don't believe that fear is a good a feeling that you should instill.
No, we are teaching the right thing here, and it's just to illustrate that we do not want to, even if it shows a bad
Just
OPLL.
for also operating on it, which Akhil said that as you follow these patients up, more often than not, they tend to develop dysfunction. But and it's not true that if you operate on them, then the recovery is going to be much less than what you would have operated on them earlier.
Yeah.
But
No, so I think I would differ with Mazda. So there is literature that if you operate in cervical myelopathy with mild MJOA, the recovery chances are more than 75%, versus if you let them progress and go to moderate or severe MJOA. So
Yeah,
I
but
think
that we are talking about, Akhil, is that if they are bedridden and
symptoms,
you reach
correct,
that
with
stage,
symptoms. Correct. So no fear, but I think it is important that we counsel the patient so that in future they don't come back and tell us that आपने बताया नहीं था हमको.
Correct.
I had something like this.
Red flags are important.
Yes.
Absolutely.
So I'll go ahead with the next case.
what did you do for trapeziitis?
Analgesics. So this patient is 64-year-old male who came with neck pain and again bilateral upper limb radiculopathy. He had grip weakness, gait instability, bladder bowel was normal, no other comorbidities except on some glaucoma medication. This is what the MRI looks like. Chaubey sir, what do you think, sir, at this stage? क्या करना चाहिए इसको?
If he is a classical case of myelopathy, then he deserves surgery, and I'll go from the posterior.
Sir,
Okay.
what levels would you want to do in him?
I generally go a level, one level up and one level down. That is
So
what I do.
3 to 6.
So
That means every patient will be 3 to 6 only.
So maybe up to part of the 7 also.
Okay, upper part of 7.
Upper part of 7. So I will do the laminectomy the way we do, and I'll always do the flexion extension. And if this looks like kyphotic, so I will always do the fixation.
Fixation. So fixation would also be 3 to 7, 3 to 6?
3 to 6. 3 to 6.
3 to 6 fixation for this patient.
For this
Aditya, anything that you want to add? You'll do posterior for all, I think.
So basically, again, here, as per classification by Dr. Bojraj, if you see there is focal kyphosis, if you obliterate that kyphosis, if you keep just hand over there, you see the overall lordosis
is okay.
Cervical spine. So here are standard laminectomy posteriorly. With Dr. Bojraj, I had seen during his fellowship, I had seen his 25-30 years follow-ups, which he had done in KEM days. He has done only laminectomies and patients are not having kyphosis. So again, I'm not making a blanket statement that one should not fuse in.
But in this case,
that's what. So what is the age of the patient?
I think 60, 64.
64. So and by and he's a retired person, kind of, right?
But
Demanding.
he's also.
So basically, for me, young individual with demanding lifestyle, so definitely I'll fuse them. But in this particular case, I'll do just C3 to C7 laminectomy. I won't fuse this patient because I have seen wonderful. I have seen wonderful follow-ups maybe literature or panelists over here
No, I
agree
agree
to
with
that?
you, but I understand what you're trying to say. But
Yeah.
I mean, according to our teaching, there is not enough lordosis for the cord to fall
Lordosis.
back. So the chance of only getting
But
good
that's what,
result with only decompression,
believe me, I have
you
seen
think it still can
similar
work?
cases. Maybe next time, if opportunity is there, then I may present few of those cases also, where
Yeah,
wonderful
that
follow-up
it can work.
and clinically patients have done
But
wonderful.
why don't you want to fuse it?
No, because with sir, I have seen long-term follow-ups where
And
there are
what yourself?
increasing kyphosis, and in my hands also, in whatever 13 years of my experience, even in my hands, I haven't seen up till now increase in kyphosis. I might be wrong. In coming few years, they may come
So
with.
in which case would you do a fusion?
In this particular case, definitely no.
If it was more widespread, would you think about it? Or
Kyphosis,
more
absolutely. Kyphosis, if it's more than
more
this,
kyphotic?
there is no question of
Okay,
posterior surgery. Then
okay,
anterior only
so
one has to approach.
okay,
But if at all, if it's a focal kyphosis with overall intact lordosis, definitely posterior is good enough.
okay. Akhil, you wanted to add something?
Can I see the X-ray, please? Just.
Sorry. Yeah.
Or
And
the
this X-ray is like,
I think
I mean,
it's not neutral X-ray. If I might be wrong, because the mandible level and everything, I somehow I feel it's not a neutral X-ray.
I think I have a flexion extension here. This is a
Uh,
flexion extension.
So still, I'll go for posterior in this.
Yeah. Akhil?
okay. So I would, for looking at this flexion extension, in the extension, we are able to achieve good lordosis. I might consider going posterior, but I will definitely fuse after doing laminectomy. However, I saw that you drew the K line and the OPL is going beyond the K line. So I mean, like, I may even consider doing a corpectomy at that level and just doing that single level.
That's what I was getting
if
to you
you-
at. Would you think about that, a corpectomy at that level and then
Yeah,
turn it
yeah.
around or just a corpectomy and
Just
fuse
a
it there?
corpectomy, I think should be more than enough. 2, 3, 4.
Mazda, I see
C6
you are
corpectomy.
agreeing.
C5
C6 corpectomy.
C5 corpectomy. What advantage and disadvantage do you have with that approach?
advantage is that you are able to restore the spinal alignment and
Okay.
realign the lordosis, which will also take care of the neck pain. If you allow patients to be in kyphosis, there is a general tendency for neck pain to persist. And it's an anterior pathology. If the OPLL is not very severe, or even if it is to some degree, you can deal with it anteriorly, especially because it's at one level. And it's enough to decompress. If you do one level, you are going to get the 4-5 disc and the 6-7 disc, which is causing compression, and there's no compression anywhere else.
And your disadvantage of going here or doing this?
I don't feel there's any disadvantage except for if the OPL is very ossified and you may have a CSF leak, or you may cause inadvertent cord injury trying to release it. But those risk factors are very, very negligible, in my opinion,
In your opinion?
in my hands.
So I'll just go ahead. Now, in my opinion, it's always, going anteriorly in OPLL in our private cases is always fraught with danger, and I do not like to do that, especially if you see that there is some significant bone there, and so this is my standard approach is just to posterior multi-level decompression and stabilization, and these patients do very well. Uh, Chaubey sir, patient got C5 palsy after 1 week.
I don't know. I don't know because I have not seen. You people will not accept this, may not accept, but I've really not seen the C5 palsy in posterior decompression. And most of the time, we only do the decompression without fixation. But whenever needed, you must do the fixation, like this case.
Yeah. Sir, I think
Interesting part over here, Dr. Satyen, is in spite of
yeah.
not having so much of lordosis, still you got C5 palsy. Because if lordosis is much, you expect more
The
cord.
chances are more, but that's what we said. We don't know. This happens.
Interesting over here. Yeah.
Can happen in anyone.
Yeah.
So I think I don't want to go ahead for more cases. We'll just looking at the time, we'll stop here. But I want a few points from all of you, especially start with our senior Dr. Chaubey sir. Whenever we are operating these patients, how is it different from your routine lumbar surgeries? Okay, what are your points for safe spine surgery in cervical myelopathy surgeries? What do you want to tell the patients? What do you want to tell your anesthetist?
Yeah, posterior, anterior, whatever.
Posterior.
Posterior. So any surgery when you are doing for the myelopathy, monitoring of blood pressure is very important. Mean
Very
arterial.
good. Yes. Excellent point, sir.
So this is the one part. Another thing, you have to be very, very gentleman surgeon. You see,
don't be orthopedic.
You can't be whether orthopedic or the non-orthopedic, it doesn't matter. But in posterior cervical surgery, the overall blood loss is not more than 20 ml. Unless if it bleeds, epidural bleeding is there, which is significant. Otherwise, there is no bleeding. So basically, you have to do and you have to should not do the facetectomy except C5. Only at the level of C5, you do the facetectomy, you do the root decompression. Otherwise, you have to spare the facet. And that is good enough for the myelopathy.
Great, sir.
Or if there is any radiculopathy, so you know that which radiculopathy is there. Suppose if there is a C6 radiculopathy is there, that root you must decompress, whichever the side the radiculopathy is there. So root decompression plus the cord decompression only medial to the facet.
Only medial to the facet. Great, sir. Very good points. I think taking home a message on this was that maintain your mean arterial pressure above 100 or above ideally is the best thing to do. During surgery, take care of your positioning, eye position, etc. And when you're doing it, do it very delicately. Ideally, use burrs or you use your QSAs, etc. for so that you do not touch the cord. No touch technique through the dura whenever you're operating on these patients. Using neuromonitoring, etc. is quite useful. And do a proper job and be very careful. So well done that there should be hardly any blood loss when you're doing these surgeries. So excellent point made. Mazda, do you want to add any points on anterior surgeries so to have a safe anterior surgery when you're doing cervical decompressions here?
I would say do a very, very good subplatysmal dissection if you want to prevent complications such as airway edema and dysphagia. I usually don't cut the omohyoid. That some people say can also exacerbate swallowing difficulty. And if possible, do a drilling of the posterior osteophyte complex in all cases, especially if you're doing it at C4-5 to avoid a C5 palsy. Put in as big a cage as you can without over distracting it.
And is there any point that you want to make on your endotracheal cuff?
So if you're doing a long surgery, let's say beyond 1.5 to 2 hours, then deflate the cuff midway to the operation for about 5 minutes or so, or not, maybe even 3 minutes is enough, and then reinflate it. Some studies show that reduces the risk of recurrent laryngeal nerve lesion.
In my own experience, I've seen that we put the endotracheal cuff pressure at the lowest possible without it starting to leak, and that has decreased the chances of dysphasias, dysphonias a lot. I mean, it has been zero since that I've started that. So great points that you've made here. Akhil, About counseling, do you want to add any points before take-home messages for these patients?
No, I think the most important part in counseling is you communicate with the patient that the surgery that you're doing is to prevent further deterioration. That is the main objective. And whatever benefit we get, we will take that as bonus. All the patients will be very happy with the post-operative outcomes in that way.
Yeah, proper counseling is very important, and we need to make sure that they understand why we are operating and what they should get out of it. Also, counseling for regarding potential complications is very important, as there can be catastrophic complications in these surgeries, especially in your early stages. So you need to know when to stop and how much to do, so that you do a very good job. As Dr. Chaubey said, very subtly, it has to be a gentleman surgery. This is what he's trying to say, that don't be aggressive. Just do the most important points and that leave it around. Aaditya, what do you want to add anything in this for take home for these patients?
So just to add to the anterior surgery, I always keep Ryle's tube. Just
Right, so it's good. Yeah, it's a good point.
because esophagus, I can so that I can
Palpate it.
esophagus, so the retraction part can be taken care of properly. So
Yep.
that just point I wanted to make sure has to be covered.
Yeah.
So second, positioning point of view, eyes should be checked always once you place your position, whatever maybe the headrest or means whatever you are using, just make sure your eyes are free. And
Yeah.
always keep head end of the table high,
Slightly elevated. Yeah.
elevated one.
So that you have less venous congestion and
Less
it's
venous
easier to
congestion.
operate.
Yes, absolutely.
Great.
And
Great.
there should not be any compromise on the vertical dissection. Vertical dissection in anterior surgery. You should not work in a very limited space. Your vertical dissection should be as good as possible. And another thing which I want to add, whenever we are evaluating the cervical spine, we must evaluate the shoulder pathology.
Back to basics.
In each and every patient. We
Yes.
must see that what is the state of shoulder.
Correct.
It is very silly, sir, but a lot of patients come with these problems, and we end up seeing that they actually have periarthritis of shoulders, and the entire treatment changes.
And not only that, even the acromioclavicular joints, etc. You evaluate everything, the whole shoulder girdle.
Yeah.
Evaluate when you are doing the cervical spine surgery.
Yeah. Thank you, sir. Thank you, gentlemen, for a very productive evening. I want to thank our audience as well, and hope that you enjoyed it. You can send in some feedback if you wish to. We will be coming back next month again with our continuing academic program from Bombay Spine Society, and hope to see you more involved in these programs. Also, thanks to Intas for sponsoring this. And we'll see you soon. Good night, everybody.
Good night. Thank you.
Thank you. Thank you.
Good night.
Thank you.